Hello, citizens of Internet. I am Dr. Ajit Virkud from Mumbai, India. I am a professor and ex-head of Department of Obstetrics and Gynecology. This is a channel that gives something extra. This podcast is inspired by the success of my textbook, which has been widely received by students and professionals alike. Each episode will delve into selected excerpts giving voice to my structured approach to topics in gynecology. Whether you're a student, a seasoned practitioner, or simply interested in the field of gynecology, I hope you will find these discussions both enlightening and engaging. Thank you for tuning in, and let's explore the world of gynecology together.
Today, we're diving into a really common, but maybe often misunderstood, part of gynecological health, endometrial polyps. So our mission here, in this deep dive, is really to give you a clear picture. What are these polyps? Why do they happen? What impact can they have? How do we find them? And what are the current ways to manage them? We're drawing heavily on insights from Professor Ajit Virkud. He's a real expert, wrote Modern Gynecology.
Yes, and we're also pulling from a detailed podcast discussion he was part of. Indeed. And endometrial polyps are, well, essentially they're small tissue growths. They project out from the inner lining of the uterus. That's the endometrium.
Okay.
And it's important, I think, right from the start to make a distinction. These aren't fibroid polyps.
Right. Different things.
Completely different. Fibroid polyps come from the muscle wall of the uterus itself.
Yeah.
So our chat today is specifically about these endometrial ones.
Got it. Exactly. Okay, so let's start unpacking this. When we say endometrial polyp, what exactly are we talking about?
Well, Professor Virkud's definition is pretty clear. It's an abnormal growth of tissue. It contains the endometrial glands, the supportive tissue called stroma, and blood vessels.
Okay.
And this growth projects out from the uterine lining, so it takes up space inside the uterine cavity. They can be, quite small or sometimes big enough to fill a good portion of the cavity.
So it's not just a bump on the surface, it's a distinct structure made of different tissues.
Precisely. And the term polyp itself, it's quite general in medicine. It just means any small growth or bump sticking out from a mucous membrane, usually inside a hollow organ.
Like where else?
Oh, you see them in the stomach, the intestine, colon, even the nose. And just like in those places, uterine polyps, endometrial polyps, can be single or you might find multiple ones.
Okay, single or multiple, that helps. Now, Professor Virkud also mentions terms like sessile and pedunculated. Can you break those down?
Sure. Think of pedunculated like a mushroom or maybe a pendant on a necklace. It's attached by a relatively narrow stalk.
Okay, got that visual.
Sessile, on the other hand, has a broad base. It's attached more directly to the lining without that distinct thin stalk. And it's worth noting the pedunculated ones seem to be more common in the uterus.
Right, the stalked ones. And size-wise, what are we typically looking at?
Most are actually quite small, generally up to about 3 centimeters max dimension. Clinically, we often differentiate less than half a centimeter is small, more than half a centimeter is large.
Right.
And location. Usually they're found on the upper part of the uterus, the fundus, especially near where the fallopian tubes enter the cornual regions.
All right, so we've got this picture now. Small growths, uterine lining, stalk or broad base, often up top. Now, how common are these? Is this something a lot of women deal with?
Oh yes, they're quite common. Getting exact numbers is tricky, as Professor Virkud points out, but estimates suggest maybe 10 to 15% of women who don't have any symptoms might have them found incidentally.
Really? That high even without symptoms?
Yeah, and that number jumps quite a bit, maybe 20 to 70% in women who come in with abnormal uterine bleeding.
Oh.
And interestingly, the prevalence seems even higher in women struggling with infertility. The reported range is wide, 11 to 45%.
Wow, 11 to 45% is a huge range for infertility cases. Why such a big difference?
Well, it probably reflects differences in how studies were done, the diagnostic tools used, who exactly they were studying.
Sure.
But the consistent finding is definitely a higher prevalence in women facing fertility issues compared to the general population. Oh, and they also become more common as women get into their 40s, sort of the 5th decade.
Okay, so we know what they are, how common they are. The big question then is, why? Why do they develop? What starts these growths?
That's the million-dollar question, isn't it? What's the root cause?
Yeah.
According to Professor Virkud, the precise cause, the etiology, it's still a bit elusive. We don't know for sure. But there are several pretty strong theories being looked at.
Okay, can you walk us through some of the main ideas?
Well, one major theory revolves around hormones. specifically estrogen and progesterone.
Makes sense for the uterus.
Exactly. It turns out polyps tend to have more estrogen receptors and fewer progesterone receptors compared to the normal endometrium right next to them. So this hormonal environment might, encourage growth and also potentially stop the lining from shedding properly during a period. Think of it like estrogen pushing growth and not enough progesterone effect to trigger the normal breakdown.
So the signals for the period to start, they might not work as well on the polyp tissue itself.
That's the idea, precisely. Another area getting attention is how the cells are regulated. There are proteins involved in normal cell turnover, one called BCL2, which stops cells from dying programmed cell death, or apoptosis.
Okay, keeps them alive.
Right, a survival signal. And another called Ki67, which marks cells that are actively dividing, proliferating. In polyps, you often see higher levels of BCL2.
So they're not dying off like they should.
Potentially, yes. That survival signal might be too strong, letting cells accumulate. And higher Ki67 suggests they're also dividing more rapidly.
So living longer and multiplying faster than normal.
That seems to be a strong possibility, yes. And then there are genetic factors being investigated, too.
Okay, like mutations.
Sort of. Cytogenetic studies looking at chromosomes have hinted that abnormalities, especially in evolving chromosomes 6 and 20, might play a role. It looks like rearrangements or translocations, specifically in the stromal cells, the supportive tissue cells, could be involved.
So maybe some genetic changes in the lining tissue itself make it prone to forming polyps? Any other potential causes on the radar?
Yeah, Professor Virkud also mentions some other molecular players. Things like P63, an enzyme called aromatase P450, steroidogenic factor 1. Also, something called stromal P16 immunoreactivity seems to show up consistently in polyps, which might give clues.
It sounds like a really complex mix of different molecular signals being explored.
It really does. And interestingly, there's some newer research looking at possible links between endometrial polyps and other common conditions like endometriosis and adenomyosis.
Oh, really? Like they might share some underlying cause.
Possibly. The exact connection isn't clear yet, but it suggests there could be shared biological pathways or maybe factors that predispose women to more than one of these conditions.
Fascinating. So no single smoking gun, but likely multiple interconnected things going on. Okay, now, are there specific things that put a woman at higher risk for developing these?
Yes, definitely. Several risk factors are pretty well recognized. Having higher levels of estrogen is a big one.
Right.
That could be estrogen, the body makes itself endogenous estrogen, or estrogen taken from outside, like in hormone therapy.
Right, that ties back to the estrogen receptor findings you mentioned. What about medications?
Absolutely. Certain drugs are linked to higher risk. Tamoxifen is a major example.
The breast cancer drug.
Exactly. It's a selective estrogen receptor modulator, but in the uterus, it can act like estrogen. So women on tamoxifen have a higher chance of getting polyps, but also endometrial hyperplasia, even cancer.
Right.
And interestingly, the polyps in women taking tamoxifen can sometimes look a bit different under the microscope. One idea is that tamoxifen might also stop that programmed cell death, apoptosis we talked about.
So it's kind of a double whammy estrogen-like effect, plus maybe stopping normal cell cleanup.
That seems to be the thinking. Similarly, postmenopausal women on hormone replacement therapy, especially if it's estrogen only, also seem to get polyps more often. Again, likely due to that constant estrogen stimulation of the lining.
Okay, estrogen seems key. What about lifestyle factors? Anything there?
Yes, obesity is another known risk factor.
How does that connect?
Well, fat tissue, adipose tissue, can actually produce estrogen. There's an enzyme called aromatase that converts androgens into estrogens. So more body fat can mean higher circulating estrogen levels, which could boost the risk of polyps.
Ah, okay. Clear link there between lifestyle and hormones. Any other major risk factors?
Inflammation is another area being looked at.
Inflammation inside the uterus.
Yeah, the idea is that localized, maybe chronic inflammation in the endometrium could contribute. You have immune cells like mast cells releasing substances, cytokines, growth factors that can encourage tissue growth and new blood vessel formation, angiogenesis. And notably, an enzyme involved in inflammation, COX2, has been found at much higher levels in polyps compared to normal endometrium.
So it's not just hormones. Inflammatory processes might be stirring the pot, too.
That's the current understanding, yes. And supporting this idea of growth and blood supply, studies have shown higher levels of VEGF, that's a big factor for blood vessel growth, and TGF-beta1, which is linked to fibrosis or scarring, in polyps. And this fits with seeing more Ki67, too, showing more cell proliferation.
All right, so we've covered potential causes, risk factors. How do these actually show up? What signs or symptoms might make someone suspect they have a polyp?
Well, first off, it's really important to stress that many, maybe most, endometrial polyps are asymptomatic. Lots of women have them and don't know it.
Right, no symptoms at all.
Exactly. But when symptoms do happen, the number one most common one is abnormal uterine bleeding. AUB is the abbreviation often used.
Right.
Professor Virkud points out that something like 68% of women with polyps, both before and after menopause, report some kind of abnormal bleeding.
I have a pretty high percentage. What actually causes the bleeding from the polyp?
It's thought to be related to congestion in the polyp's supportive tissue, the stroma. This can lead to veins getting sluggish venous stasis and maybe some superficial breakdown or even tissue death, necrosis right at the tip of the polyp.
Pouch.
Yeah. And interestingly, the likelihood of having abnormal bleeding if you have polyps seems to go up as women get older.
What other kinds of symptoms might someone notice?
Well, any bleeding after menopause is a red flag, obviously, or even just a blood-tinged discharge. Some women might get more painful periods, dysmenorrhea, maybe because the uterus is contracting, trying to expel the polyp.
Like cramps trying to push it out.
Possibly. And if it's one of those stalked, pedunculated polyps and it actually pokes through the cervix into the vagina,
Ooh.
it can cause bleeding after sex, post-coital bleeding. And in rare cases, if a polyp gets really large and starts to break down, it could cause a sort of foul-smelling, watery, bloody discharge.
Okay, none of that sounds pleasant. Now, you mentioned earlier a higher rate in women with infertility. How exactly do polyps interfere with getting pregnant?
Yeah, that link is definitely there. They've been associated with both primary infertility trouble conceiving the first time and secondary infertility, difficulty after having had a child before. The reported rates vary a lot, like we said, maybe 3.8 to 38.5% for primary, 1.8 to 17% for secondary.
So quite a range again.
Yes, but the good news is studies show that removing polyps can improve pregnancy rates for women doing things like intrauterine insemination, IUI.
Oh, that's positive.
And sometimes even just removing the polyp in women considered subfertile has led to them conceiving naturally afterwards.
That's fantastic news for people struggling with fertility, but what's the mechanism? How do they actually get in the way?
Well, several ideas have been put forward. They might physically block the spot where an embryo tries to implant,
Right?
or they could cause local inflammation, making the lining less receptive. If a polyp is near the opening of a fallopian tube, maybe it blocks sperm getting through.
Right, a physical blockage.
Or it could just change the overall environment, the receptivity of the whole endometrium, making it less suitable for a pregnancy to start. Because of all this potential impact, the general recommendation is usually to remove any polyps found incidentally when someone's being evaluated for fertility issues.
Makes sense.
And there was one study suggesting that after polyp removal, women doing IVF had similar implantation rates to women who never had polyps.
So taking them out seems to level the playing field, fertility-wise. Now, the big worry with any growth is always cancer. What's the deal with polyps and malignancy?
Okay, this is key. The vast majority, the overwhelming majority of endometrial polyps are benign. They're not cancerous.
That's reassuring.
It is. But in a small percentage, estimates range from about 0.5% up to maybe 3%. They can either become hyperplastic, which means excessive cell growth, sometimes a precancerous step, or they can undergo actual malignant transformation into endometrial cancer.
Okay, small percentage, but not zero. What types of cancer?
The most common types found are endometrioid adenocarcinoma and serous adenocarcinoma. Those are typical types of endometrial cancer.
And is that risk higher for certain women?
Yes, it seems to be, particularly in postmenopausal women who have abnormal bleeding. In that group, the risk of finding precancerous changes or actual cancer in a polyp might be as high as 6%.
Okay, so postmenopausal bleeding with a polyp needs careful attention.
Definitely. And other risk factors for malignancy in a polyp include the polyp being large, especially over 40 millimeters, so 4 centimeters.
Wow, that's quite big.
Yeah. And also having used tamoxifen or hormone replacement therapy, those seem to increase the risk slightly too.
Okay, so size and those hormonal factors again. If a polyp is removed, what does the pathologist actually see under the microscope? What are they looking for?
Microscopically, a typical polyp shows endometrial glands that are often kind of dilated, maybe cystically enlarged, sometimes filled with mucus. You'll see mononuclear cells, and these characteristic vascular pedicles, those stalks with blood vessels surrounded by connective tissue, maybe some glands too.
Okay, that's the general look. But Professor Virkud also mentioned different histological types, didn't he?
Yes, there are subtypes based on their microscopic appearance. The most common are called hyperplastic polyps. These seem to arise from the bottom layer of the endometrium, the basal layer, and they're often linked to estrogen stimulation. Sometimes they can exist alongside a more widespread thickening or hyperplasia of the whole lining. And especially in large polyps in postmenopausal women, you might find localized areas of atypia cells looking a bit abnormal.
Atypia being a potential warning sign.
It can be, yes. Needs careful evaluation. Then there are atrophic polyps.
Atrophic, meaning shrinking.
Kind of, yeah. You see these more in postmenopausal women. They probably represent polyps that were previously functional or hyperplastic, but are now sort of regressing or breaking down.
Okay, what else?
Functional polyps are the least common type. Here, the glands actually look similar to the surrounding endometrium and seem to respond to the monthly hormonal cycle.
Ah, interesting. So even a polyp can sometimes follow the cycle.
Some can, yes. And then there are adenomyomatous polyps.
Adenomyomatus. Bit of a mouthful.
It is. It means they have varying amounts of smooth muscle and fibrous tissue mixed in with the endometrial glands and stroma. And importantly, there's a variant called atypical adenomyomatous polyps. These are considered sort of mixed tumors, and they have a known association with or potential to transform into endometrial cancer, maybe around 9% risk.
Right, so that subtype definitely needs close watching. And the last one was pseudopolyps.
Yeah, pseudopolyps. These are usually small, less than a centimeter, flat base. Microscopically, they actually look identical to the normal endometrium around them.
So why call them polyps?
Because they bulge out, but they seem to be a temporary thing. They often only show up in the second half of the cycle, the secretory phase, and then disappear with the period.
Okay, more like a transient fold or something.
Got it.
So we understand what they are, the symptoms, the risks, the different types. How are they actually diagnosed? What tools do doctors use?
Well, there are several ways to visualize them. Macroscopic diagnosis. Often the first step is a transvaginal ultrasound.
Right, the standard ultrasound.
Exactly. On the screen, a polyp might look like a brighter spot, hyperochogenic, usually with smooth edges, inside the uterine cavity. Sometimes you can even see little cystic spaces within it.
But you said fibroids can look similar.
They can, yes. So ultrasound findings aren't totally specific just for polyps. Submucosal fibroids can sometimes mimic them. Oh, and the best time to do the ultrasound for this is usually around day 10 of the cycle, after the period when the lining is thinnest.
Okay, day 10. What else can ultrasound tell us?
Using Doppler color flow or power, Doppler can add info. Sometimes you can see a single blood vessel feeding the polyp at its base. It's called the feeding artery sign. And that can help distinguish it from a fibroid, which often has blood vessels more around the edges, like a rim. 3D ultrasound is also becoming more common.
What's the advantage of 3D?
It gives a better sense of the polyp's volume and its precise location, front wall, back wall, near the top, etc.
Okay. Are there other imaging methods besides standard ultrasound?
Yes, a really valuable one is saline infusion sonography, or SIS, sometimes called sonohysterography.
Saline infusion. What's that involve?
It's basically doing the transvaginal ultrasound, but first, a small amount of sterile salt water, saline, is gently put into the uterine cavity through a thin catheter.
Well, I do that.
The fluid gently pushes the walls of the uterus apart and provides contrast. It outlines any growths inside much more clearly. Polyps usually show up as smooth, bright masses sticking out into the fluid. SIS is often considered the gold standard imaging technique for things inside the cavity.
I see. Better visualization. Any older methods still relevant?
Well, hysterosalpingography, HSG, which uses X-rays and contrast dye, was used historically to look for blockages or abnormalities inside the uterus and tubes, and it could sometimes show polyps. But with modern ultrasound and SIS, it's not really the first choice just for finding polyps anymore.
Right. So what's the ultimate diagnostic tool then?
That would be hysteroscopy.
Looking inside directly.
Exactly. A hysteroscope is a thin, lighted telescope with a camera on the end. It's inserted through the cervix right into the uterine cavity.
Here you can see it.
You can see everything directly. You can tell for sure if it's an endometrial polyp or a fibroid polyp. You get a great 3D view, size, shape, exact spot. And the huge advantage is you can often remove it right then and there.
The see and treat approach.
Precisely. Professor Virkud really emphasizes that nowadays, most polyps can be diagnosed and removed in an office or outpatient setting using hysteroscopy. It's become very streamlined.
Okay, so hysteroscopy is really key for both diagnosis and often treatment. So just to recap the imaging signs suggesting a polyp.
Sure. On ultrasound, you're looking for that bright hyperechoic area in the otherwise dark endometrial cavity. On Doppler, maybe that single feeding artery. And on SIS, a well-defined mass inside the fluid-filled cavity.
But none of those are 100% definitive on their own.
Correct. The definitive diagnosis always comes back to looking at the tissue itself under the microscope.
Right, the histopathology. So even if you see it clearly with hysteroscopy and take it out, it has to go to the lab.
Absolutely, without question. Every single bit of tissue removed needs to be examined by a pathologist. That's how you confirm it's a polyp, what subtype it is, and most importantly, rule out any hyperplasia, atypia, or malignancy.
Makes sense. And what does the pathologist typically see to confirm it's a polyp?
Usually they see endometrium that doesn't seem to be responding normally to hormones. It might look like cystic hyperplasia regardless of where the woman is in her cycle, and it doesn't shed with menstruation. Sometimes, less often, it looks like functional endometrium that is cycling. Key features are often those dilated, crowded, funny-shaped glands, dense fibrous stroma, and those thick-walled blood vessels in the stroma. You might also see signs of cell proliferation even when the surrounding normal lining isn't proliferative.
Okay, got it. So we know how they're diagnosed, what they look like. Let's shift to management. How are endometrial polyps treated?
Well, first, Professor Virkud points out there's no known way to actually prevent them from forming in the first place.
Okay. No prevention.
And routine screening for them in women without symptoms isn't generally recommended. It's not considered worthwhile or cost-effective.
So we don't look for them unless there's a reason. What happens when they're found or if they're causing problems?
Right. Then the management strategy really depends on a few things. Are there symptoms? What's the estimated risk of malignancy based on factors like age and polyp size? Are there fertility concerns?
Okay.
Broadly, the options fall into conservative surgical treatment, more radical surgery, or conservative non-surgical approaches.
Let's start with non-surgical. When might that be an option?
Watchful waiting or just observation can be perfectly reasonable for small polyps, say, under 10 millimeters or 1 centimeter, especially if they're not causing any symptoms.
Why just wait?
Because small polyps actually have a pretty high chance of just shrinking or disappearing on their own spontaneous regression. And the risk of cancer in such small asymptomatic polyps is very low. So often the recommendation is just a repeat ultrasound in about 6 months to see if anything's changed.
Okay. What about in postmenopausal women?
There's some thought that combined hormone therapy might reduce development, and maybe a drug called tibolone could help. But watchful waiting is still an option for small asymptomatic ones.
So for the small, quiet ones, just keep an eye on them. Are there medications used to actually treat existing polyps?
Well, the levonorgestrel IUS, the hormonal IUD, is often used to prevent polyps and hyperplasia in women who are taking estrogen therapy or tamoxifen.
Right, prevention in high-risk situations.
Exactly. There's been some research into whether things like birth control pills could make existing polyps regress.
And can they?
Maybe sometimes. The thinking is the progestin in the pill might trigger cell death, apoptosis in the polyp, reduce cell division, have anti-inflammatory effects, or just quiet down the endometrium. Interestingly, one study suggested pills might work better for the flat sessile polyps than the stalked, pedunculated ones.
That's specific. What about standard hormone replacement therapy? Does that affect polyps already there?
It's a bit unclear. Theoretically, it might help by thinning the lining overall, but studies haven't really shown it shrinks existing polyps much. Maybe because, as we said, polyps often lack enough progesterone receptors to respond.
So hormonal treatments seem more for prevention or maybe small ones, not really shrinking bigger established polyps?
That seems to be the general picture, yes. Some other hormonal meds like Dynagest or Danazol are sometimes used before hysteroscopy, mostly to thin the lining and make the surgery easier and potentially safer. Dynagest has shown some promise for reducing bleeding and operative time too.
Okay, so primarily surgical removal is the main treatment for symptomatic or larger polyps.
Yes, when intervention is needed, hysteroscopic polypectomy, removing it via hysteroscopy, is absolutely the gold standard.
And this can often be done in the office?
In many, many cases, yes. The specific tool used often a resectoscope with an electric loop, or maybe a bipolar probe, depends a bit on the polyp size and location. Using the resectoscope loop seems to have very low rates of the polyp coming back.
When would you choose one tool over another?
Generally, bigger polyps, maybe over 2 centimeters, or ones high up in the fundus, are often better tackled with the resectoscope. Same for sessile, flat-based ones. Smaller, stalked polyps not in the fundus might sometimes be snipped off with tiny scissors through the hysteroscope.
Sounds very precise and minimally invasive compared to older methods. That really highlights the leap forward with hysteroscopy. Are there risks with hysteroscopic removal?
It's generally very safe, low complication rate, low recurrence rate. But like any procedure, there are small potential risks. Infection, bleeding, maybe pelvic inflammatory disease. Very rarely, a tear in the uterus or cervix could happen, or complications from the fluid used to expand the uterus. Afterwards, patients might have some light bleeding or cramping for a short time.
So you mentioned D&C before.
Right, dilation and curettage. Historically, that was used for abnormal bleeding, but it's a blind procedure you're scraping without seeing.
So you could miss the polyp.
Easily. Studies showed D&C missed polyps maybe 50 to 85% of the time because they can just move out of the way of the curette. With hysteroscopy allowing direct visualization and removal, D&C is really considered obsolete for treating polyps specifically. There are also newer hysteroscopic tissue removal systems that basically shave or morcellate the polyp away. Those are also proving to be good options.
And the main advantages of doing it hysteroscopically.
Big ones are that it's often an office procedure, which patients appreciate. It's seen as definitive treatment because removing the polyp right at its base seems to really cut down recurrence, and patient satisfaction tends to be very high because it usually resolves the bleeding symptoms effectively.
Okay. And after the procedure, what's the follow-up?
Critically, as we keep saying, all the root tissue, the polyp, any lining samples must go for pathology.
Right. What happens based on the results?
If it's benign, maybe just routine follow-up is needed to watch for any recurrence down the line. If they find hyperplasia with atypia, the treatment usually involves hormones, either oral progestins for 6-9 months, or putting in a hormonal IUD. Sometimes hysterectomy is discussed, but it's not always needed.
And if it's malignant?
Then, unfortunately, it's treated as endometrial cancer following the established protocols based on the cancer stage and grade.
So those pathology results are absolutely crucial for guiding the next steps. Okay, well, we've covered a huge amount of ground here. Definition, causes, risks, symptoms, diagnosis, treatment. What's the main takeaway message for our listeners?
I think the key thing is that endometrial polyps are common. They can present in different ways, sometimes with no symptoms, sometimes with bleeding or fertility issues. While there's a small risk of malignancy, especially postmenopause, it's generally low. And importantly, we have really good modern tools, especially hysteroscopy, to both diagnose and effectively treat them, often in a minimally invasive way.
Absolutely. And a reminder to our listeners, if you are experiencing any abnormal uterine bleeding or have concerns, please do talk to your healthcare provider. Don't ignore symptoms.
Definitely. And maybe a final thought to leave listeners with, given all the research digging into why polyps form and their links to other conditions, what might the future hold? Could we see new ways to prevent them, or perhaps more non-surgical treatments emerge down the road? It's certainly an active area in gynecology, something to keep an eye on.
Great point. Well, thank you for joining us for this deep dive into endometrial polyps. Until next time, stay informed.